There's a really overwhelming body of evidence now that supports buprenorphine dramatically improves a variety of different health-related aspects of addiction illness. In so many ways, it's an example of a medication, when provided in the right context with the right supports, which for any given individual can look very different, can be immensely beneficial in reducing the harms associated with opioid use disorder and ultimately improving the quality of life.
So I feel lucky that we've been able to use buprenorphine in the way we do today, which is actually very different from what the teaching was when I was in medical school many years ago, where now we can implement this therapy to our patients in many settings, including the emergency department, and the feedback we get from the patients is very positive. It's a very difficult medical problem to have, very difficult to treat, and this option is a lot better than others for many patients. So historically, many patients were treated with methadone. It's a good option for some, but not for everyone. So it really has proven to be a wonderful asset for us in treating a terrible disease.
Buprenorphine has offered a substantial tool into our armamentarium with opioid recovery in terms of giving patients back some sort of semblance of normalcy to their lives, giving them medications that they can take home and treat it like any other disorder, going about their lives, being normal, productive members of society. And I think that's really their goal.
The notion of a low-threshold buprenorphine project is really one that I think is key to this discussion, because what it really means is that we don't really make any demands of our clients. People can come, they can become enrolled, engaged in our low-threshold buprenorphine project, and the only goal that we set for our clients is the goals that they set for themselves.
When people come here, more often than not, they have used that day, so we explain to them how important it is to wait until they start feeling signs of withdrawal, because nobody wants to get that dope sick, right? So if you take Suboxone and you're high, you're going to get thrown into precipitated withdrawal. And almost every single client understands what that means. So they know that they have to look for sniffles, or they know that they have to look for itchiness or stomach cramps, and then they take the medication when they feel they can't hold on anymore. All of this is done in the comfort of their home. So if they need to call, we're available the next day, and they can discuss what's going on. So this Suboxone didn't work for me last night because of this, and I had to use, all right, fine, let's discuss going forward.
I would say that beyond the medication itself, buprenorphine, which is an important part of really assisting people in not having cravings around using whatever opiate they're using, the entire program and the harm reduction approach that we use is part of what actually helps patients transition from feeling like their opioid use is out of control to having support and people who are on their side as they initiate a process of using a medication to mediate their cravings.
The only difference with like a private physician's office and this treatment facility is that we don't do in-house inductions. It's not necessary. It's been proven that home inductions are also as effective with treating withdrawals when they come in withdrawal, so that's what we do here.
Once the patient understands the medications, what it can do, they can take it safely at home. They're connected to care, they don't have to go every day, but they do follow up to see how they're doing with their provider. It's easy for the provider to give, it's easy for the patient to take, and really requires very little education on both parties to get them up to speed with what they need to know.
You need to get community support as well with this. You need to actually go out and you say, these are the programs that we have to support you.
It's a chronic medical problem. We have to erase the stigma attached to it that is limiting people from the physicians and nurses and medical community from doing the things they can do to best treat these patients. So I think the education there, and I think a lot of that comes from the next thing, which is shared experiences. When I have a patient who comes in and they're in active withdrawal and they're a good candidate to get buprenorphine, they feel better. You see them feel better. When you speak to patients who are engaged in care with medication-assisted therapy, they say it's changed their life. It decreases their desire to use street drugs sometimes, which could hurt them if they relapse, which happens with many medical conditions. I've seen many a hypertensive patient who didn't take their meds and come into the emergency department with severe hypertension. This happens for many medical conditions, but in this case, if they are not compliant with the care and they have a lapse in their therapy and use an illicit substance, or even too much of a prescribed substance, they're likely not to die. You're saving their life. And I think if you can wrap your head around those key elements of the treatment, you'll be in a good place.
One of the really powerful strategies that have taken place across the country, and now which we're embarking on in Staten Island, is the framework of a learning collaborative, where you bring together experts with clinical experience, with familiarity with the delivery of addiction care, and enable folks that are hopefully starting to adopt these practices to be able to get support from the mundane, as far as the day-to-day screening tools, different frameworks that can be used, to the much more complex issues of challenging and complex cases. And the spirit of a learning collaborative is really to encourage engagement of as many members in the community in a new form of care, as well as creating a forum for dialogue, support, and hopefully the continued expansion of MAT, particularly in Staten Island.